Hi everyone, this is Naveen again. Um, n- and today's topic is hypernatremia. I know this is a pretty simple one in that, there's really only one treatment that's giving water for the most part. But still, I want to give us a method of formal assessment and just some of the common things that we're going to see in the ICU, just so we have the tools needed to really handle this without thinking too hard. Whenever we talk about a natremia problem, like I said with hyponatremia, it's not that it's an actual sodium problem, but rather it is a water problem. So we're going to use our same equation that we focused on with hyponatremia, and that's Edelman's equation. This is the equation that says that the sodium concentration in the blood equals the exchangeable sodium and potassium over the total body water. Now, hyponatremia is an issue where the ratio favors total body water, and there's too much total body water. But hypernatremia is the opposite. This is a situation where there is too little water relative to the salt in the body, and that leads to a high concentration of sodium. So going back to that bucket analogy that we use frequently in the hyponatremia talk, the bucket, if humans are just a bucket full of salt and water. In the instance of hypernatremia, it's that the ratio has way too much salt in comparison to water. Now, just like with hyponatremia, the goal isn't to fix the salt. The goal is how do I fix the water? And so for that, we have to find a way of adding more water into the system while preventing losses of water out of the system. And the problem is one of these two situations. It's either that a person is unable to get enough water into the system, or the person for some reason is losing too much water relative to how much they're able to get into the system. And that's the essence of hyponatremia. Keeping that in mind, there are really only four main causes of hyponatremia that I want to talk about, or buckets, I guess you could say, of issues. The first one, and this is the most common one that we're going to see in the ICU, is osmotic diuresis. Now, when we talked about hyponatremia, we talked about that people have to stay in balance. So every osmol that they intake leads to an osmol that has to come out. And with that osmol, water has to follow because urine is a combination of osmols and water. In osmotic diuresis, a person is getting so much salt or glucose or protein or some sort of osmol just dumping into the system. And this is obligating to stay in balance that we have to dump the same sodium, glucose, or protein out. But unfortunately, this comes mixed with water. And if this person is not getting water for whatever reason, but getting all this protein or glucose or salt, well, then they're going to be staying in osmotic balance, but they're going to be losing net water because urine has to travel with water. Okay? So this is what osmotic diuresis is that we give so many osmols that we obligate urine output, and this leads to loss of water. Now, the main situations this is going to arise is if a person is getting tube feeds, because in the ICU, we often tend to target these insanely high protein goals of like 1.3 to 2.5 grams per kilogram of protein, and that leads to a lot of osmols. Another one is a high BUN. In patients that have acute kidney injury or on steroids or have a GI bleed, they can have this high BUN that has to be urinated out. And another one is high glucose. This might be a patient who has diabetic ketoacidosis, for example, and then there's this obligate glucose output from the urine because it's overwhelming the tubular maximal glucose absorption. And so the kidney just starts peeing out glucose, but because glucose is an effective osmol when it's in the urine space, water is dragged out with it. Now, the second etiology that we're going to talk about, just going to erase a little bit here. The second etiology we're going to talk about is uh, salt diuresis. Now, this is a really uncommon one, but this is the idea that a person is you're getting a lot of salt and losing a lot of salt in their urine. And when they lose the salt in the urine, salt is an effective osmol in the urine, and so it drags out water. This is a really uncommon one. And generally speaking, you might see this with like a salt wasting syndrome, where a person is just getting way too much salt in their feeds, but not drinking water. Um, this is really hard to achieve, but it theoretically can happen. I usually never call this type of diuresis, but it is one of the ones that we need to be aware of, and we'll talk about how we diagnose it. The next one is an uncommon one, but this is the one that you get tested on the most, and it's a water diuresis. Another way of saying this is it's our formerly known diabetes insipidus, now known now known as vasopressin resistance versus deficiency. So if you find this on a test, you're going to see the terms vasopressin resistance or deficiency used rather than nephrogenic diabetes versus central diabetes insipidus. These are incredibly rare. We'll talk about how we diagnose them. They're incredibly rare, but these might be one of an instance where you actually need either nephrology or endocrine help. Otherwise, this should largely be managed without their help. The last one is just that a patient is losing water and not getting it back. We call this extrarenal losses, and for some reason has an inability to get them back. This is an incredibly rare instance. That has a few rare instances and a few that are not so rare. For example, every single day we lose sweat, we poop, we urinate, and there's going to be some water losses through all of that. Particularly when we're sick, we have increased metabolic activity. This increased metabolic activity is going to lead to increased losses of fluid compared to usual. A burn patient might be another patient who has their skin is not intact, and so they're losing a lot more water than a normal person would. And then they're not getting enough water back in return. Now, patients who have an intact thirst, if you have an intact thirst, your sodium should really never get above 148 if you are able to get water. So a person who has a sodium of 140, 5 and above will start to say, I'm thirsty, and will try to drink water. The one instance where they're going to get hypernatremic is when they're unable to drink water. This might be someone you've made NPO. This might be someone who is being neglected. For example, there's no one around to give them water. They're too weak to grab water themselves and drink it. They're altered and unable to speak with us. A really common situation is a patient with dementia. In patients with dementia, they often just sit there, they waste, and they get weaker and weaker, and they're unable to drink water. Sometimes there are attentive people, and they will ask them, are you thirsty? And then those patients will say, yes, I'm thirsty, and they'll get their water. But oftentimes they're not able to advocate for themselves due to their significant end-stage dementia. A rare situation is hypodipsia. I have seen a patient with hypodipsia and a sodium of 170 plus. This is a patient who, no matter what their sodium increases to, says, I'm just not thirsty. This is an incredibly rare situation that can happen. It usually is associated with some sort of brain injury, whether that's like an infarct or a traumatic brain injury or something like that. All right, so these are the 4 types of etiologies that will lead to hypernatremia, the most common one being number 1, and then one that you might see admissions for is number 4, this dementia patient in a nursing home who is maybe being neglected, and the patient comes in with a sodium of 180 because no one has been giving or asking or giving water to this individual. Rarely you'll see number 3, and really number 2 is one that is very difficult to actually call, and it's probably something else. Okay, so that's the etiologies of hypernatremia. Let's quickly talk about how to evaluate, and then we're just going to go into a couple quick scenarios, and that should be the end of this video. Okay, let's talk about the evaluation in order to determine how much um, um, osmoles are being urinated out or inability to obtain water. So this will help us determine which of the 4 etiologies, which I've written on the side here, could it be. So the first thing that we're going to do, just like with hyponatremia, is understand what the kidney is doing. This is going to be by obtaining urine lytes. We'll start with the urine osmol, but also go ahead and get a sodium, a potassium, a chloride, a urea, and a UA, because the UA has some reference of what glucose is in the urine. Even though it's not a measured amount, it's still useful information. Okay. Now, why do we need the urine osmol? Because we need to determine whether or not the patient's kidneys are doing the right thing. Just like with hyponatremia, we need to understand what ADH is, how ADH becomes active. Now, when a person's serum osmolarity is increasing, such as in the situation of true dehydration, where our serum osmolarity is rising, ADH should be turned on, because that way we can increase the water retention that we have in our body. We should have concentrated urine and try to keep as much water in our system as possible. This is the kidneys doing the correct thing. Okay, so you can either have concentrated urine, and this is generally referred to as greater than 600 um, milliosms per liter in on our urine osmoles, or you can have not concentrated, and this is generally referred to as definitively less than 300 milliosms per liter in our urine. And then there's this gray area that is 300 to 600. Okay. Now, with concentrated urine, this means that the kidney is doing the right thing. Kidney is intact, and now we have to figure out which of the causes it is, and it's going to be either cause 1, 2, or 4. Okay, and we'll talk about how we differentiate between the two, and it depends on the volume of urine that's being put out per day. All right, so we'll get back to that in a second. If it's not concentrated urine, definitively not concentrated urine, this should make you think that this is a water diuresis, number 3. Now, this was previously known as your diabetes insipidus, but we should probably be referring to them as, we had nephrogenic before. These are now referred to as vasopressin resistance versus deficiency. Deficiency is previously known as central diabetes insipidus. Resistance was previously known as nephrogenic. The reason I bring this up is what you're going to get tested on is vasopressin resistance versus deficiency, not DI. And then there is a gray area of 300 to 600 that we may see where you should expect the kidney to concentrate, but for some reason it's not concentrating. Now, this could be water losses or partial diabetes insipidus, partial vasopressin resistance or deficiency. Rather partial vasopressin resistance. But this could also just be because of really bad CKD or acute kidney injury, which we see frequently in the intensive care unit. When a kidney is not functional, it's going to have trouble concentrating urine appropriately, and so it may still try to be doing the right thing. ADH as a system may still be intact. It's just that the kidney's function is not as responsive as we want it to be due to the acute kidney injury. Okay. So if we have concentrated urine, right? If we have concentrated urine, we know it's going to be 1, 2, or 4, and then we'll go to the next step. If it's not concentrated urine, then we know we have vasopressin resistance versus deficiency, and there's a couple ways of testing this. One is the water deprivation test. It's not one that we do regularly, and I don't think clinically, I really don't think you should be needing to do this. It's still recommended sometimes, and I would really urge you to stop wasting time. Just don't think of it that way. Now, one way you can do it is quickly give a dose of DDAVP, and just once you've given DDAVP, you can assess what the new urine concentration is. If the urine concentration is high, concentration goes up appropriately to greater than 600, you know this was a vasopressin deficiency. The body's not making enough vasopressin, but the kidneys are responsive. If the urine concentration is low, so we'll say central here. If the urine concentration is low, say stays less than 300, you know this is a nephrogenic or a resistance. Okay, pretty easy workup here. Now, etiologies of vasopressin deficiency are going to be your strokes and your traumatic brain injuries. So CVA, TBI, surgeries, such as in the case of many of our pituitary surgeries, right? Your vasopressin resistance is a little bit more difficult. Some of these are congenital mutation. Some of these are due to drugs like lithium. I think this is the classic one that you're going to see. But there are other drugs that do this as well. And I think the one I've actually seen the most in the ICU is hypercalcemia. Hypercalcemia we'll talk about in a separate lecture. But one of the issues that hypercalcemia causes is an aquaresis. And aquaresis referring to, in this case, sort of a vasopressin resistance. ADH is no longer very effective, and so they lose water through the urine. Okay, so that would be the workup there. Now, if it's a deficiency, you're going to be calling endocrinology. If it's resistance, then you're going to call nephrology. And the reason for this is this generally warrants an evaluation of using NSAIDs or thiazides or a combination in order to try, as well as restricting the osmoles a person is eating per day. And this can be quite difficult. But would need long-term nephrology evaluation anyways, and so this is a great time to have nephrology input so that they can manage the patient and plug them in with the outpatient setting. But again, this situation here, I would say, is incredibly rare, and I've only seen it a handful of times, especially compared to the others. The next one that we're going to see frequently is, the next step that we're going to do if we are here, the next step that we're going to do is check the urine volume. Why is that? Well, in osmotic diuresis, we talked about how this is an excess amount of osmoles that the kidney has to pee out, and so obligate urine output is going to come out with it. And this leads to a patient losing water through their kidneys, but the kidneys are trying to concentrate. Okay, a salt diuresis is similar, but it's with salt. And then extrarenal losses are that the kidney is trying to withhold everything, but it's not getting an excess number of osmoles per day. So how do we make that determination? Well, a normal person is going to be eating between 600 and 900 osmoles per day. And so this is obligate urine output. If we see that the urine osmol times the urine volume, and the units are going to be milliosmol per liter and this is just going to be per liter, so you should get milliosmoles per day. So we can say liter per day here. If the milliosmoles per day is less than 1,000, then you are dealing with number 4 above. Okay. If it's greater than 1,000, then you are dealing with number 1 or 2, but most likely it's going to be number 1. All right. Why is that? In the ICU setting, we often put patients on tube feeds, or they're very metabolically active, they're on steroids, they have a high BUN due to an acute kidney injury. These all are filtered by the kidney, the nephrons, and then these go into the urine and then force obligate urine output. So if the urine osmoles per day is greater than 1,000, we know that they're getting an excess number of osmoles into their body that have to be put out in order to maintain equilibrium. And so then water is dragged out with it. So if they have a concentrated urine, but their concentrated urine is still leading to polyuria and excess water output because of the number of osmoles that have to be dumped per day, then they're going to slowly lose water, right? If we go back to our equation, total body water is going to decrease. And if it decreases, we get hypernatremic. So this is where understanding what our sodium, our potassium, our urea, and our glucose are. Now, in most situations with tube feeds, it's going to be that your urea is quite high, or your glucose is high, especially in DKA. If, on the other hand, it's that your urine sodium plus your urine potassium is greater than your serum sodium plus your serum potassium, this is usually going to be somewhere around like 150 or plus, right, in the situation of hypernatremia. So if this is higher than your serum, that means that you're peeing and dumping out salt. That's the one instance where you're going to have a salt diuresis rather than osmotic diuresis. But almost always it's going to be that your urea or your glucose is high, and so this is an osmotic diuresis in the setting of tube feeds. Okay. And so that's how we figure out, is it 1, 2, 3, or 4? Is it is it 1, 2, or 3? The fourth instance is going to be that we actually are making concentrated urine and we're not getting a significant number of osmoles per day. It's just that a person is not getting adequate water intake, and so they get hypernatremic. This could be a person, again, who doesn't have access to water or does not have an intact thirst mechanism. Okay, so now in summary, that's how we determine 1, 2, 3, or 4 as our etiology for hypernatremia. It's just really these two main steps, and there's a couple branch points in these steps. Right? Now, finally, I want to talk about some scenarios, and we will be done. The first scenario is just the straightforward, how do we calculate free water deficit? Right, free water deficit. Now, many of you are going to do MD Calc. I guess that's okay. In my experience, MD Calc for some reason seems to undercalculate it frequently, and then it just leads to this taking longer to fix. Let's just give you the equation. It's pretty straightforward, though it may take a couple times deriving it in order to memorize it. But the equation is the free water deficit equals your current sodium now versus your sodium goal minus 1 times your total body water. Okay? How do I get this equation? Well, my current sodium times my total body water now is the amount of sodium that I have. My current sodium concentration times my total body of water. I should actually change this. I'm sorry. This is not have brackets. This is just a parentheses, right? Is my current sodium that's in my body. Now, if I add water to the person, they're going to have, and my goal is a sodium goal, right? So say my goal is 140 here and I'm at 150 here, right? Well, then what I'm doing is I'm taking my total body water and adding X to it. And this is the equation, right? My concentration times my total body water. I'm not changing my sodium, my total sodium in my body, so that these two sides should be equal. The only thing I'm doing is I'm changing my new concentration and by adding water to the body. And I'm calculating for X. So I can solve for this. How do I solve for this? Well, I'm first going to divide by my sodium goal. So my sodium concentration over my sodium goal times total body water equals total body water plus X. Now I'm going to subtract total body water. I get sodium concentration over sodium concentration goal times total body water minus total body water equals X. And now I'm just going to factor out the total body water. So total body water times my sodium concentration over my goal minus 1 equals X, and that's the equation above. Okay, and this is how we derive that equation. Now, how do I get total body water? Again, as we talked about, it's multiplying their weight by some factor between 0.5 and 0.6. 0.6 for a young male, 0.55 for a young female, and anyone above 65 has a weight times their 0.5 is their total body water. So a 70 kilo individual greater than 65, for example, would have 35 liters of water in their body. And that's how I would calculate their total body water. When I do this equation, I'm going to get their free water deficit in this current moment, okay? Um, but that doesn't, the water that I'm going to give them through the day does not factor in their insensible losses for the day, their urine output, their pooping, and everything else, right? And so this is still going to be an underestimate at correcting their sodium. So for example, if I have a patient who is currently at a sodium of 150 and my goal is 140, right? And then they're a 70 kilo individual who's 70 years old, so their total body water is 35 liters. Well, I'll plug it into this equation, so 150 over 140 minus 1 times 35 liters equals my goal. And I can calculate that out really quickly. Just going to do some math, so 150 to 35. And this gives me an X of 2.5 liters. But that's my deficit in this moment. That doesn't include my insensible losses for the day. Insensible losses are generally 8 cc's per kilogram in an unstressed state, but in our ICU patients, it's going to be higher than that. This also doesn't account for poop. In general, maybe what you can do is just add 1 liter, and that's a relatively good estimate as a starting point. And so this person, if I'm truly trying to correct them in a single day, I should be giving them 3.5 liters. Okay, so this is how I calculate free water deficit. It's this equation here. All right. All right, let's erase this. One question that you might ask me now is, well, what is our goal sodium change? This is generally not as strict as hyponatremia. It is still recommended to change your sodium by less than 12 per day based on the guidelines, but the evidence for this is very weak. There's decent pediatric data, but in adult data, it's very weak, and there is now maybe some meta studies that are saying that less than 24 per day is probably safe. In general, I just try and correct by 10 to 15. As long as I'm going in the right direction, I'll know I'll hit it eventually. Especially if patients in the ICU, you have a couple days. How many patients do you see whose sodiums are greater than 195? Even if they were sorry, 185. Even if they were, they would correct in 3 days if you're doing it appropriately, right? So I just try and correct pretty aggressively, but by a 10 to 15 per day. Um, but the guidance for this is actually quite poor, and so we'll leave it there. Now, the final scenario that I want to bring up is something called something where so scenario 2 here is your volume overloaded patient plus hypernatremia. This is a situation that we run into where you have a patient who is total body up, but they're also hypernatremic. So this total body water is up, but their salt content relative to their total body water is even higher. Now remember from our hyponatremia talk, volume equals salt plus a unit of water, okay? Whereas in hypernatremias, we are specifically just talking about water, right? Free water is only referring to the unit water without the salt, okay? When you have a volume overloaded patient, your goal is natriuresis. How do I get salt out of their body in order to remove the water unit with that salt and their total body volume decreases? It's a 1-to-1 change in this ratio of Edelman's equation, so it does not affect their concentration of sodium. Should not affect their concentration of sodium. But free water, on the other hand, is just manipulating the total body water portion. Okay? In a volume overloaded patient with hypernatremia, what I frequently see is I'm afraid to give water to this patient because their volume is going to increase and then we'll run into trouble with their volume overload. That's the incorrect way of approaching hypernatremia in a volume overloaded patient. Rather, you should split them up into the goal of natriuresis and increasing their total body water. Okay? How do we do this? We just add diuretics. Do it aggressively. Add diuretics aggressively. But then give back water. Give this back to them. Give them D5W. Give them water boluses through an NG tube. Just give them back water. But be aggressive with your diuretics. And you're saying, I'm worried about my creatinine. Don't be worried about your creatinine. If they're truly volume up, their kidneys will be fine with the diuresis. Otherwise, you're not confident in your volume exam. That's the way it really is. So you need to just do natriuresis with diuretics and then give them back water. You can do both at the same time. Split them up into 2 separate problems and target both problems individually, and you'll correct the ratio while also getting rid of the salt plus water unit that you want to in order to help with their volume overload state. All right. Thank you so much for listening again. This is hypernatremia.